All right, now we are moving on to part 2 of the ACLS videos. If you're just picking up here, this is basically I've taken images of the algorithms and some other important information, and I'm walking my way through them, discussing them. It's helpful for me. I learned through the process, and hopefully you will too. So previously, quick overview what we've covered. Going back, we talked about this circular algorithm for cardiac arrest. In other words, somebody's heart stops, kind of showing how you just kind of repeat the same thing over and over and over again. This is more showing an algorithm approach, so it's just linear. And then this one here is after the person has come back and now their heart's going again. They call this return of spontaneous circulation, ROSC. And then we talked about what to do if the person has a pulse, but it's a bradycardia, and what to do in that case. And it looked like, you know, if the person, just a quick review, if the person had hypotension or signs of shock or acute heart failure, those things like that, then you would give them atropine, dopamine, or epinephrine. And so that's a good thing to remember there. In the instance where a person has tachycardia, you wanted to consider slowing their heart down. Every single one of these instances, just about, except for the one that indicates synchronized cardioversion, which was if they had hypotension or acutely altered mental status or signs of shock or ischemic discomfort or those sorts of things. In those cases, if they have these things, then they would do the synchronized cardioversion, where it's basically like shocking their heart in a certain way. And then they said, even in this instance, if it's regular and narrow, then you would use adenosine. So what I mean by regular and narrow is that these beats are kind of the same in each instance, and then the same space apart, regular, and then the QRS, which is here's Q, there's R, and there's S, is narrow. Okay, that means less than 0.12 seconds there, or milliseconds, or whatever it was. Anyways, I think it's seconds. So in that case, if it is narrow and whatever, then you can consider adenosine. Every other one of these instances also considered adenosine as long as it's regular. Okay. Sometimes I say monomorphic too as well. So if in any instance, if it's regular, whether it's wide or narrow, this is a wide QRS or narrow QRS. You want to consider the adenosine here. The difference though was that if it's a wide QRS, with a tachycardia, you use an antiarrhythmic, whereas if it was like antiarrhythmic means like procainamide, amiodarone, or sotalol. But if it was a narrow QRS, you would consider doing a vagal maneuver or a beta blocker or calcium channel blocker. In every instance, if it's regular, use adenosine. Adenosine stops the heart temporarily and then brings it back up again. You want to give this heart a break. It's almost like pressing the reset button. So adenosine is often the right answer. Just remember though, the difference here, wide QRS, antiarrhythmic. Narrow or just normal QRS, beta blocker, calcium channel blocker. All right, now what we're going on to here is if the person has had a stroke, or if we suspect that they had a stroke, what do we want to do here? How do we walk through this? So first of all, we want to identify the signs and symptoms of a possible stroke. And there are a lot of those, and I don't think that's a discussion for this. Sometimes they can, certain eye signs or tongue signs or, just lots of things like that. But then you're going to, activate the emergency response. It says critical EMS assessments and actions. So first of all, you want to support ABCs. And what they mean by ABCs is airway, breathing, circulation. Okay, so make sure their neck and everything is open, and you want to breathe for them, and then you want to pound down on their heart or whatever. Check those things. Check the ABCs. Give oxygen if it's needed. Perform pre-hospital stroke assessment. Establish time of symptom onset. So you want to figure out when did this start. When was the last time they were acting normal? Then you want to triage to a stroke center. Alert the hospital. And check the glucose if possible, because sometimes, the glucose can be a factor with this. So hopefully they arrive to the emergency department, before 10 minutes have elapsed. That's kind of the goal here. So hopefully you live close. Immediate general assessment and stabilization. So you want to, again, assess the ABCs, vital signs, provide oxygen, obtain IV access, and perform laboratory assessments. Do they have something strange going on in their blood? Check their glucose. If they have high or low glucose, treat that if it's indicated. Perform the neurologic screening assessment. A lot of times you'll ask them certain questions, or have them move their eyes around, or have them stick their tongue out, and different things like that. Have them walk, maybe. Activate the stroke team. Order emergent CT or MRI of the brain, and this is because sometimes it can be ischemic, or sometimes it can be hemorrhagic. And you do very different things if it's ischemic versus hemorrhagic. For example, there's a fibrinolytic therapy, which basically breaks up blood clots. And if somebody's hemorrhagic, you definitely do not want to be giving them something that's going to break up their blood clots and cause them to hemorrhage even more and die. Okay, but if they're ischemic and there's a blood clot that's causing it, then you want to consider fibrinolytic. So that's an important reason to consider the CT here. And of course, obtain a 12-lead ECG. An MRI can tell you if they have like a tumor or something in there, or a cyst or something. So after you've done that stuff, these are all your ABCs and the glucose and this the basic things. Hopefully it hasn't been longer than 25 minutes by this time. So you've done all these things by that point of time. 15 minutes on top of the 10. So now you're going to do immediate neurological assessment by stroke team or designee, and must have been that activate the stroke team thing. Now they've showed up. Okay, here's your stroke team. This sounds funny to me. Review the patient history. You want to find out, what did you have, some sort of trauma, or are you using drugs, or have you been sick lately, or have this ever happened before, or those kinds of questions. Establish time of symptom onset or last known normal. And find out how long has this been. Hopefully you ask that up here as well. Perform neurologic examination. So this is NIH stroke scale or Canadian neurological scale. What you have here is this special test you can figure out. You can put them on a neurological scale to figure out how bad it is, or whatever. Okay, so now we're looking here. What does you get your results of your CT back? Remember you order the CT up here, and now you want to find out, is this ischemic? In other words, no hemorrhage. Or is this hemorrhagic? Is this person bleeding in their brain? Or is the person not getting blood to their brain? Or neither. So if there is a hemorrhage, okay, then you want to contact a neurosurgeon, because this guy may have to have his brain drilled and blood drained out of there or whatever. I mean, this is a big deal. Send this guy to the neurosurgeon immediately if there's a hemorrhage. If there, it says, consider transfer if not available. So basically it's out of your hands here. It says, looks like here, it says begin stroke or hemorrhage pathway, admit to stroke unit. Yeah, there we go. So what if there wasn't a hemorrhage? What if this guy had some sort of, blood clot or something in there? Well, then the CT would show that, hopefully, and the probable acute systemic stroke, and consider fibrinolytic therapy, is what I was talking about earlier. And we're going to go over some of those fibrinolytic therapies a little later, but basically they're supposed to break down these blood clots and allow the blood to restore to the brain. So it says you want to check for fibrinolytic exclusions, for example, recent surgery, things like that. I don't remember all of them, but I think we go over them a little bit later. You don't want to give to somebody fibrinolytic therapy if their body isn't going to be able to handle them. It's going to kill them. So lots of things to consider here. Repeat neurological exam. Are deficits rapidly improving to normal? So if they're getting better, that's gonna be important. But if they're not, if they're getting worse or staying the same, and they just have a horrible neurological score, it's gonna change your therapy course here. So it says patient remains a candidate for fibrinolytic therapy. So can they take the fibrinolytic therapy or can they not? So if they can't, give them an aspirin, send them to a neurosurgeon. He's going to have to do some brain drilling or something, whatever those neurosurgeons do over there, right? By the way, the CT, I didn't mention this, so the CT should be done. You should get the results back before 45 minutes have passed. So 10 minutes to get to the arrival of the ED. Within 25 minutes, you've finished all these important things here. And then 45 minutes, you got to decide whether or not, to take this hemorrhage or no hemorrhage approach. Start maybe getting some fibrinolytic therapy if it's indicated. And not going to cause further problems. So let's say yes, they can take the fibrinolytic therapy. So you need to review the risks and benefits with the patient. Basically, you want to try to avoid a lawsuit, all right? You want to include the patient in on these decision makings. You tell them, here's what could go wrong if we give it to you. Here's what could go right if we give it to you. And then you let them decide. Hopefully they make a decision that's good. So you can give them the TPA. TPA is tissue plasminogen activator. No anticoagulants or antiplatelet treatment for 24 hours. So this is within 60 minutes. And then within 3 hours, begin post RTPA stroke pathway. Aggressively monitor blood pressure per protocol for neurological deterioration, emergent admission to stroke unit or intensive care unit. And I think all that was pretty straightforward. So let's move on here. So now what we're going to be talking about is coronary syndromes algorithms. But part of me kind of wants to go and look at the fibrinolytics for a second. Here's the fibrinolytic checklist. So we're going to get back to this coronary algorithm thing. So let's talk about these fibrinolytic checklists for a second. So back here, when you were trying to determine, is this patient a candidate for fibrinolytic therapy? Here's what you go through. Has the patient experienced chest discomfort for greater than 15 minutes and less than 12 hours? Okay, so it's more than 15 minutes, less than 12 hours. So somewhere that's a big margin there. So if the answer is yes, then you want to then you ask the question, does the ECG show a STEMI, which is a certain kind of like heart attack, or new or presumably new, this is another finding on there. The answer is LBBB. If the answer is yes, then are there contraindications to fibrinolysis? If any one of the following is yes, fibrinolysis may be contraindicated. So you cannot give them fibrinolytic therapy if any of these things say yes. But man, there's a lot of things to go through here. So first of all, 15 minutes to 12 hours, that's a good thing. If no, you need to stop. Don't give them fibrinolytic therapy. If they've had a STEMI or presumably new LBBB, stop there. So this is yes. It's between 15 minutes and 12 hours. Does the ECG show a STEMI or a LBBB? Yes. And are there any contraindications to fibrinolysis? So let's look at the contraindications. So one of them here is high blood pressure. Why is that important? Well, if you've got really high blood pressure, you can have a brain bleed if you give them a fibrinolytic, okay? It's a bad deal. So high blood pressure, let's define that. Greater than 120 to 200 for their systolic, or their diastolic greater than 100 to 110, okay? So if the answer is yes, you got to go back up and stop here. Answer is no, you can move on. All right, what about right versus left arm systolic blood pressure difference, greater than 15 millimeters mercury? So basically, if one of their arms has higher blood pressure than the other one, some weird's going on, okay? That it's probably not what we think it is. So stop there if the answer is yes. Next is a history of structural central nervous system disease. Okay, if they got something weird going on there, like maybe a Barry aneurysm or something like that, probably want to say stop there. Significant closed head facial trauma within the previous 3 months. So if they've been like hitting the head with a baseball bat or had a car accident where they bashed their head in or something, probably can't do it there. The stroke greater than 3 hours or less than 3 months. So basically, if they had a stroke in the past 3 months. So that's another thing. Next one here is recent, within the last 2 to 4 weeks, major trauma surgery, including laser eye surgery. Wow, so basically any surgery within the last 2 to 4 weeks. Any history of intracranial hemorrhage, bleeding, clotting problem, blood thinners, or are they pregnant? That'd be bad. Serious systemic disease, such as advanced cancer, or severe liver or kidney disease. Any of these sorts of things. So any of those answered yes, got to stop. Okay, but if all these things are okay, you can move forward. Basically, surgery, trauma, high blood pressure. Pretty much a summary of those things. Or a stroke, or yeah. Okay, so is the patient at high risk? If any one of the following is yes, consider transfer to a PCI facility. So again, more questions here. Step 3, heart rate greater than 100, systolic blood, so this is basically tachycardia, or their blood pressure less than 100, so low blood pressure. Pulmonary edema, we've got rails. Signs of shock, cool and clammy. Contraindications of fibrinolytic therapy, which would be these things, or required CPR. So, yeah. So those are good things to view. So there was another thing here which was listing the fibrinolytic therapy. That's not it. Here we go. Fibrinolytic therapy for STEMI. So this is a quick overview of them. Boy, there's a lot of stuff here on fibrinolytic stuff, so this is just crazy. So absolute contraindications: any prior intracranial hemorrhage, known structural cerebral, this is like a review, known structural cerebral vascular lesions or atrial malformation, known malignant intracranial neoplasms, check for primary metastatic, ischemic stroke within 3 months, they had a stroke recently, except acute ischemic stroke within 3 hours, suspected aortic dissection, basically it's like their aorta is getting all bulged and stuff, active bleeding or bleeding diathesis, including menses, significant closed head trauma or facial trauma within 3 months. So those are absolute. Can't do it in any of those instances. They'll bleed to death. Relative contraindications: history of chronic, severe, poorly controlled hypertension. They got bad hypertension, can't do it. Severe uncontrolled hypertension on presentation, so it's like greater than 180. History of prior ischemic stroke in the last 3 months, dementia or known, intracranial pathology not covered in contraindications, traumatic prolonged greater than 10 minutes, CPR or major surgery less than 2 weeks, recent within 2 to 4 weeks internal bleeding, non-compressible vascular punctures for streptokinase antiplase. These are different types of like TPAs, I believe. Prior exposure greater than 5 days ago. In other words, if they had these things recently, can't give it to them. Or prior allergic reactions agents, of course, the pregnancy, acute peptic ulcer, current use of anticoagulants like warfarin or heparin. The higher the INR, the higher the risk of bleeding. So these are all things that could be contraindications for fibrinolytic therapy. And that's the last one. So we've gone through pretty much everything now except for this slide here, which is kind of 2 slides. And it's a little messy. This one I scanned. This one I took a picture of my phone because the scanner didn't work. So let's go through this. So acute coronary syndromes algorithm. So basically you've got this blood vessels around your heart. And we're talking about what to do if one of those things is all messed up. All right. So symptoms suggestive of ischemia or infarction. So ischemia, basically there's not enough oxygen getting to it, and infarcted means it's all the blood's cut off from it. So EMS assessment and care and hospital preparation. Monitor, support ABCs, be prepared to provide CPR and defibrillation, administer aspirin and consider oxygen, nitroglycerin, morphine if needed. Basically what you're doing here is are they breathing? Do they have the airways open? Are they circulating? Whatever. Give them the CPR if needed. So the next thing, give them oxygen. You've got to open up the blood vessels. So sometimes that blood vessel's cut off, and you need to kind of draw a picture here of what I'm meaning by this. Let's say this is the blood vessel, and let's say it's got a bunch of junk in it like this, and there's not much blood getting through. Well, if you relax this blood vessel, make it bigger like this. This thing's still the same size, but now there's more blood that can get through. So that's kind of giving the nitroglycerin help with that, and morphine maybe help relax them too, or whatever, or maybe it's painful. Obtain 12 lead EKG if ST elevation. Notify receiving hospital with transmission. Or interpretation. Note time of onset and first medical contact. Notified hospital should mobilize hospital resources to respond to STEMI if considering pre-hospital fibrinolysis. Use fibrinolytic checklist. We talked about that. Concurrent emergency department assessment, less than 10 minutes. Check vital signs, evaluate oxygen saturation, establish IV access, perform brief targeted history, physical exam, review complete fibrinolytic checklist, check contraindications, obtain initial cardiac marker levels. So basically, there's like troponin and these different things like that you can look at to see if the person's had a heart attack. I'll check those. Obtain initial electrolyte and coagulation studies. Obtain portable chest x-ray less than 30 minutes. Intermediate ED general treatment. If O2 sat less than 94%, start oxygen at 4 liters per minute. Titrate aspirin 160 to 325 if not given by EMS. Nitroglycerin, sublingual or spray, morphine. So there's all these crazy things you can do. Okay, so whatever. Depending on the ECG interpretation, there's 3 different interpretations of the ECG you can get. Okay, it could be an ST elevation, could be an ST depression, or it could be normal. So let's start with ST elevation, or new, presumably new LBBP. Strongly suspicious for injury. Okay, call this an STEMI, ST elevation, myocardial infarction. So STEMI. So what do? First, you want to do the adjunctive therapies as indicated. Do not delay reperfusion. Come down here. So the time of onset of symptoms is less than 12 hours. So it's been less than 12 hours since it started. Well, if it has been less than 12 hours, then your goal is down here. Then you want to so the reperfusion goals therapy defined by patient and center criteria, door-to-door balloon infiltration, door-to-balloon infiltration, PCI goal of 90 minutes, door-to-needle fibrinolysis goal is 30 minutes. Okay, that's interesting. So we want to get the balloon catheter kind of opens things up. Fibrinolysis is going to break down the clots. So from the time they've come in the door to the time they got a balloon in them, you want 90 minutes, but if it can do fibrinolysis, you want that to be like 30 minutes. Okay, so now going over here, what if it wasn't an ST elevation? What if it was an ST depression or a dynamic T-wave inversion? So instead of the T-wave going the direction it's supposed to go, it goes the other way. Strongly suspicious for ischemia. This one over here was suspicious for injury. STEMI was injury. This one's ischemia. So high risk, unstable angina, non-ST elevation, myocardial infarction, or an NSTEMI as sometimes you like to call these. So you're going to find the troponin elevated or high-risk patient. Okay, if that's the case, I didn't walk through this one, but this is the same thing you'd done if it was greater than 12 hours as well from the STEMI. So STEMI greater than 12 hours, or they had an NSTEMI. We want to do the troponin elevated high-risk patient. Consider early invasive strategy if refractory ischemic chest discomfort, recurrent persistent ST deviation, ventricular tachycardia, hemodynamic instability, signs of heart failure. Any of those things, you want to start adjunctive treatments as indicated, such as nitroglycerin, which is going to open up the blood vessels like I showed over here with these blood vessels on the side to the left. Heparin, okay, that's like a blood thinner, or prevents it from coagulating, anticoagulant rather. Consider per-oral beta blockers, that kind of slows the heart down a little bit. Consider clopidogrel, that's another type of blood thinner, or anticoagulant, similar to aspirin. Also consider glycoprotein, 2B or 3A inhibitors. Those are other things that are going to stop the clotting cascade, stop clots from occurring. Why? Because this person has ischemia. They've got something blocking off stuff. Okay. Now, after those things, I admit to monitor bed, assess risk status, continue aspirin, heparin, and other therapies as indicated. Consider ACE inhibitors, HMG-CoA reductase inhibitors. That's going to decrease their amount of cholesterol in their blood, bad cholesterol, and they're not at high risk anymore. Okay, so you figure out they're high risk. So that's that pathway. All right. Now, what if they're normal or non-diagnostic changes in ST segment or T-wave? This is a low intermediate risk ACS. Consider admission to emergency department, chest pain unit, or to appropriate bed and follow. Serial cardiac markers, including troponin, repeat ECG, continuous ST segment monitoring. Consider non-invasive diagnostic test. So they develop one or more of the following, such as clinical high-risk features, dynamic ECG changes consistent with ischemia or troponin elevated, then you want to go back here and take this. But if they don't, it's abnormal diagnostic, non-invasive imaging or physiologic testing. So, if nothing's normal, then there's no evidence. It must be fine. But if there was some sort of evidence with these non-invasive imaging and whatnot, then you want to admit them here to get monitored. I think that completes the rest of this video. I hope that was helpful for you, and best of luck to you.